Good morning, everyone. It looks like it's 9 a.m., so we will begin our workshop on moving research into practice and policy, the importance of implementation science. I'm Christine Andrews Stobart, and I'm the Knowledge Translation and Training Capacity Platform Lead at the Saskatchewan Centre for Patient-Oriented Research, affectionately known as SCPOR, and I'd like to welcome you all here this morning. I'm going to go over just a few housekeeping reminders. First, the chat box is being monitored, and we also have an IT specialist in attendance. If you're having problems with Zoom audio or camera, there is a helpline that can be reached, and the number is in the chat box. This session will be recorded. The presenter will be spotlighted during the presentation. Attendee mics will be off during the presentation, although we encourage you to have your cameras on. Questions can be written in the chat box to be addressed, or you can raise your hands, and we'll ask you to please introduce yourself and where you're from and speak loudly when asking a question. And then following the end of the showcase, all attendees will receive a survey, and we ask everyone to please take time to complete it because that feedback is invaluable to us. Before we begin, and in the spirit of reciprocity and truth, I'd like to honor and acknowledge I am situated on Treaty 6 territory and the homeland of the Métis. I'd like to pay my respects to the ancestors of this place and affirm our relationship with all nations and peoples of this land. Dr. Gabrielle Zimmermann is the Knowledge Translation and Implementation Science Program Coordinator with the Alberta SCPOR Support Unit's Knowledge Translation Platform. She has wide-ranging experience in research and knowledge translation that encompasses the knowledge to action cycle, from creating and synthesizing evidence to facilitating implementation of evidence into practice. Her experience includes critical appraisal of evidence, developing KT plans and proposals, and the practical application of implementation science. Gabrielle is an immunologist and an adjunct assistant professor with the Department of Community Health Sciences at the University of Calgary. And we know that she has a large slide deck and a lot of information to share with us this morning. So I'm going to turn it right over to Gabrielle. Welcome.
Thank you very much, Christine, and thank you everyone for joining us here this morning. I have no conflicts to declare. Christine did a great job of introducing me. Those are my positions, and as mentioned, I have a fairly broad research background, and I don't know how many of you may have seen this particular graph. We usually use it. It comes from the Canadian Institute for Health Research, and we use it quite often to talk about knowledge translation, but it's also a good representation of my journey along the research to practice continuum. As Christine mentioned, I have a PhD in immunology, so I started off at that far left side at the basic biomedical research bump there. And then after I was done my PhD, I ended up working for the Alberta Cancer Board. So I moved into that second hill where I was learning more about clinical research, clinical trials, health services research. I was working with the provincial tumor teams to develop clinical practice guidelines. And I became more and more interested in how research is being used, and especially being closer to that clinical interface. It was very interesting. So I took a lot of courses related to knowledge translation, read as much as I could. And then found myself really interested in that last valley number 2, about how research actually gets used in health decision-making and clinical practice. And so my current role as the program coordinator with the SCPOR unit in Alberta has allowed me to do that and work much closer with those front lines to help them get the evidence, in the best available evidence, into practice. So today we have a couple of learning objectives, and I hope that you, at the end of this presentation, that you will have gained an understanding of what implementation science is and why it is important, and also recognize how it can inform practice, which I will be demonstrating with a case study. So we don't have time to get everybody to introduce themselves, but we have a poll, and I'll get Tammy to put up the poll to get you to just identify which of these stakeholders best represent you and your role. And there's only one that you can select, but hopefully we can get a good sense of your primary role.
Sorry, technical difficulties. Poll is coming.
Uh-oh.
So sorry, it was working when I first tried it this morning. Of course, it's gonna be grumpy now.
Technology. If the polling isn't working, we can also try another method while Tammy tries to figure that out. So at the top of your screen where it says that I'm sharing my screen with you, there should be options and you should be able to click on that down arrow and select annotate. And then within the annotate, you can select a stamp and then just put a stamp on the screen near the role that best defines your current position. So we have some researchers, some health professionals, some patients, a couple from healthcare organizations. That's great. Sorry, I'm trying to figure out now the last time I was able to clear. Oh, there we go. I'm just going to clear all the drawings here. And then we will go on to our next question. So it looks like we had quite a few researchers, health professionals, and patients. So the next question is, whose job is it to move research to action? Tammy, I don't know if you managed to get the polls working.
It's saying that I'm logged in 2 places and preventing me from troubleshooting. I'm sorry, I'm working on it.
That's okay. We can just use the annotate function again, and you can just select whose job is it to move research to action. It's interesting. I can see all the little flashes popping up on the screen. And it's neat to see them all popping up all over the place. And somebody has done that nice big red circle. And in fact, that's a fantastic representation of whose job it is, because I think we all have a role to play. So I'm going to clear again. Thank you all for participating. Oh yeah, and there's a few people that put in there all and everyone. So thank you very much. You are right. That's what I would say as well. So moving research to action, this quote kind of sums it up nicely. It says, new knowledge will not, without efforts, necessarily make its way to the intended user or result in action. So we need to make it happen, and it is that concerted collaborative effort that's important. It's not any one person's role. So there's a continuum of activities by which research evidence gets into the hands of the people that can use it, and this is broadly called knowledge translation. And they vary in their level of intensity from being more passive to more active. And the level of effort increases as we move along this continuum. So at the far left, we have diffusion, and it's akin to letting it happen. It's passive and largely unplanned, and it leaves it to the knowledge user to find the information, and it assumes we know what to do with it if we do find what we're looking for. So this method is good for creating awareness, and it's typically what we as researchers have done through publications and presentations. But we're recognizing that that's not enough. So in the middle is dissemination, which is more active. It's a planned process where we're targeting our end users' needs. We're helping it happen. So our communication is targeted, and our messages are tailored to very specific audiences. And this is because awareness is good, but it's insufficient. So we need to support people to understand how to use this evidence and learn what needs to be done. And there's specific tools that we can use to help us out with that. On the far right is implementation. It's much more involved. It's the actual doing. So we're making it happen. And it's also known as application. And it involves acting on the evidence to bring about a change in practice. And it looks at systematic participation. So we're not just encouraging use in decision-making, but we're working with our stakeholders and our knowledge users to help them understand how to use this knowledge in decision-making. It's purposeful and proactive use of implementation practice and science, which is the focus of today's presentation. So as this quote highlights, moving research into practice is complex, and it requires both skill and situational judgment, which stems from experience as well as the evidence that something works. It's not just about the evidence. Just because we have the best available evidence doesn't mean that things are going to change. So think about the game of tennis. So, excuse me, can you guarantee a win in a game of tennis just by knowing the rules of the game, or by studying the detailed statistics on your opponent's performance in previous games? Not usually. So just as with tennis, you get better by doing it, reflecting, and exchanging the experiences with others. And this accumulation of practical wisdom will support informed decisions about what is likely to work in a certain situation, with certain people, in certain organizations, and under certain constraints. So there's a lot of things that we need to consider. So I've got another poll here, and I'm going to use a different format here. If I could find it. Let me just now I'm having troubles finding my other screen here. So I'm hoping that you're able to see my screen now, and it's if you have a phone or you're able to toggle between your screens on your computer, if you could go to www.menti.com, that's MENTI.com. And then there is a code, excuse me. And for those of you that can't see the screen at the same time as being on menti.com, the code is 9655038. And once you're in there, you'll see this question: what does it take to move research to impact? And you can enter in words, and once you submit, the words will start populating on my screen. At least that's the hope. It worked in practice. We'll see if the technology will will work with us. Excellent. Okay, I do see a word on the screen. We have collaboration, planning, awareness, political will. And as we start seeing the same words like collaboration, those words start to get bigger. So we can see that a lot of people are putting in collaboration, engagement.
Gabrielle, can you just give us the code one more time?
The code is again 9655038.
Okay, that will be in the box.
Yeah, we also have leadership popping up on the board. There's definitely
Gabrielle,
a lot of...
we can only see a mountain. We can only see a mountain, so maybe your screensaver.
Oh, okay, let me just... When I was trying to find the screen share, it was not working for me. So let's see if this works better. Is that... are you still seeing the mountain?
Nope, that worked.
That worked.
Okay. I have two different screens, so sometimes I'm never 100% sure which screen it's actually sharing. So, all right, so we got a lot of collaboration, engagement, leadership, money, and there's quite a few. So I'm gonna save this, and I'll put it into the presentation for after when we share the slides. But I will stop this one and then see if I can't go back to my presentation and see if I can share the presentation again. Oh, why did it go back to the beginning? Because technology is not working for me. Okay, sorry, hold. Okay, so what does it take? So we talked about a number of different things, collaboration, engagement, leadership, the funding, the dollars are important. And so there's actually a formula for success that some researchers had come up with. And so this formula includes 4 things in order for us to achieve significant outcomes. We need an effective innovation. So this might be your evidence-based program, your practice or guideline, whatever that new innovation is, it needs to be evidence-based. We need effective implementation strategies. And so these are the strategies that are used to change people's behavior to align with the effective innovation. We need to implement the strategies effectively. So this is about how well we implement, the quality of implementation. And we also need a context that enables implementation. So this is about considering where implementation is taking place. So when developing this formula, the National Implementation Research Network purposely included multiplication signs, because if any of these are equal to 0, we're not going to achieve the significant outcomes we're looking for. It's such a great overview of the major things to consider when planning for implementation. And I think a lot of what you guys have highlighted in the previous slide are going to come into some of these bubbles, and we'll talk about them in more details. And so implementation science informs the implementation strategies piece, the effective implementation, as well as the considerations for an enabling context. So what is implementation science? So this is the technical definition. It's the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services and care. So what that really means in plain language is it's the study of what works, when, why, how, and for whom. So it's the science behind how we can create change, the study of the mechanisms of behavior change and successful implementation. But why does that matter? So traditionally, our approach to implementation has relied on the Islagiat principle. And for those of you that haven't heard of this principle before, it means it seemed like a good idea at the time. But we can't just rely on that, on what appears to be a good idea at the time. We need to be more strategic and not rely on chance. We also can't assume that we know what the end users need in order to implement an innovation successfully. So these traditional approaches have a tendency to not consider key factors that influence the uptake of research evidence. And this includes the importance of context, user readiness and involvement, the complexity of behavior change, as well as timelines and the culture of decision-making and adequate resources. So implementation science helps take us there. And of course, we need evidence. If we're going to be implementing evidence-based medicine or evidence-based practice, it really should be complemented by an evidence-based implementation. And so the field of implementation science has developed to facilitate the spread of these evidence-based practices. It comes from the need to have evidence of not only what works, but how. So if you implement an evidence-based practice or a new innovation, and you don't see the patient outcomes you were expecting, that doesn't mean the intervention or the innovation failed. It more likely means the implementation failed. So we need to make sure we are increasing our chances for success and therefore to improve patient outcomes. So to guide us, there are a number of models, theories, and frameworks which can provide a better understanding and explanation of how and why implementation succeeds or fails. They are foundational to applying implementation science to implementation practice. And while they are distinct concepts, they are often used interchangeably in the literature, which can cause some confusion. So when we talk about models, these are things that can help specify the steps in a process. Theories help describe prediction and causal mechanisms, and frameworks can help explain what influence implementation outcomes. So I've got another little poll here, and you can use the annotate function again, just to give me an idea of whether or not you're used to using theories, models, or frameworks, or if you haven't been or not familiar with them. And not even just these specifically, but if you use other theories, models, and frameworks. That's great. We seem to have quite a mix. A lot of people using models and frameworks, a few people using theories, and also a few people that have not used models, theories, or frameworks. So I'm going to clear these off and go on to our next slide here. So this was a really good paper that sort of summarized all the different ways you can use models, theories, and frameworks. We utilize them to guide implementation, and they're designed to deliberately engineer change. So on the one side, they can be used to describe or guide the process of translating research into practice, and that's when you would use a process model. You can use them to understand or explain what influences implementation outcomes, and that's where you would use your determinant frameworks or your theories. And then, of course, you can use them for evaluating implementation. As mentioned, process models describe and or guide the process of translating research into practice. It's a series of steps, stages, or phases that are needed to translate research evidence into practice. And for those of you familiar with knowledge translation, this is a very common process model that is used in Canada, the knowledge to action model. And these kinds of models are useful for building a program or guiding implementation. And quite often you will use different frameworks or theories at different steps or stages. So they're complementary. Determinant frameworks describe general types of determinants or factors that are hypothesized or have been found to influence implementation outcomes, such as characteristics of the individual or characteristics of the context or setting. So these frameworks are really helpful to identify barriers or enablers, at different levels that have an impact on implementation outcomes. And so I've just highlighted a couple of different common determinant frameworks here, the Paris framework and the SCPOR framework. And they look at very similar things, but with a slightly different focus. And so depending on what it is that you're looking at and the level at which you're looking at, different frameworks can help you focus in on what you might need to be assessing. So process models and determinant frameworks are good to help with exactly what they were intended to outline the steps and stages and to think about what might influence, but they don't really address how change actually takes place. So that's why we look to theories. So classic theories describe change mechanisms and explain how change occurs. And these have been borrowed from the fields of psychology, sociology, and organizational theory. Implementation theories were developed or adapted to enhance our understanding and explanation of certain aspects of implementation. And they help address the how and the why of implementation. And the last one are evaluation frameworks, and they provide a structure for evaluating implementation. And there are specific frameworks that have been developed, especially for evaluation, but you can use other frameworks such as SCPOR and Paris to help guide your evaluation. So you don't always have to be picking new frameworks. A lot of these frameworks can be used for multiple purposes, and quite often it's easier to just use the same one and adapt it for your needs. So if you're new to theories, models, and frameworks, this is a really great website to check out. So they've based this website on that one paper that I just showed you that had the algorithm of how to, depending on what question you're asked, this is what you might be looking for. And so this website kind of walks you through that, and it gives you some examples of some different process models and where they've been used. Some have been used in public health. Some have been used in, mental health or acute care or different settings. So you can sometimes pick a model, framework, or theory that has been used in your setting. And so this kind of helps you choose a model, theory, or a framework based on what it is that you might want to be doing. So now I'm going to talk through a case study, and we're going to talk about the practical application. So looking at what does this actually look like in practice. So as I mentioned, process models are a good place to start because they're helpful to understand the key steps for moving your research evidence into practice or policy. And there's a lot of different process models out there, but the common components among many of these models include a planning or preparation phase, which is important to help us understand context and assess readiness. And they also help us think about the different levels at which this change could be happening and to consider the context and the readiness at those multiple levels. The next stage or phase is implementation. And this is where we manage change and overcome barriers. And it's really important to use targeted evidence-based strategies. And quite often we just jump to this implementation phase and try to manage the change And this is where that Islagiat principle comes in, where you just try numerous things. Whatever seems like a good idea at the time, that's how you sort of adapt and change. But we can be a little bit more strategic. And then, of course, it's important to have an evaluation or sustainability phase or stage. And this helps us define measures of success and help us document our learnings. And as I mentioned, quite often we don't spend as much time in the planning and preparation phase as we should. And that's where I think a lot of these models are really helpful to guide us through what we need to be doing in those in that phase. So our team developed this tool to highlight some of the specific pieces, but also to get you to think about how they interact, the different levels at which they interact, and the fact that change requires a transdisciplinary approach. It's also not meant to be linear, and there will be times when you have to go back and forth through these phases, as the arrows around the center suggest. There is quite a bit of overlap across these pieces, and in the center, we have the who, what, when, and how, which relates to the individuals as well as the context within which they work, and these need to be assessed and monitored throughout. So I'm going to use this tool to walk us through an example. So the specific case study that we're going to use comes from a project that came to us, to the Alberta SCPOR support units, knowledge translation platform. And so we offer support, consultation support and training across the knowledge to action cycle, which includes knowledge synthesis, knowledge translation, and implementation science. And this is offered to anyone in Alberta who is doing or would like to do patient-oriented research, or who aims to implement patient-oriented research. So one such request came from the Diabetes, Obesity, and Nutrition Strategic Clinical Network, otherwise known as the DAWN SCN, of Alberta Health Services. So the DAWN SCN is part of a host of strategic clinical networks that were created to bring together networks of people who are passionate and knowledgeable about specific areas of health. And these SCNs have core committees that are made up of patients, healthcare professionals, researchers, administrators, and policymakers. So in 2014, the DAWN SCN conducted a survey of more than 2,800 patients with diabetes who had been discharged recently from Alberta hospitals. And this survey revealed that patients with diabetes were less satisfied with their care than patients without diabetes. So the DAWN SCN is now leading a multifaceted provincial initiative with the goal to improve and standardize how patients with diabetes are cared for in Alberta hospitals. The survey highlighted that participants wanted to see improvements specifically in diabetes medication administration, which led to one of their initial priorities, basal bolus insulin therapy, or as I'll call it throughout, BIBIT. BIBIT is a way of ordering multiple daily injections of subcutaneous insulin that better replicates how our body naturally produces insulin, rather than treating high blood glucose after it occurs using the more traditional ordering of sliding scale insulin. So if we start at the first quadrant of our tool here and think about assessing readiness, the first piece is about assessing the evidence. And there's a set of questions that we need to make sure that we're asking. So first of all, does the evidence address a health priority? Is there an evidence to practice gap in the first place? And is the evidence strong enough to change practice? And this all contributes to making sure that we have an effective innovation. So in terms of our example with BIBIT, as mentioned previously, diabetes is a health priority, and that survey revealed that medication management in hospital was, again, a priority. There was an evidence to practice gap. So while we did have that strong evidence that BIBIT was a better way to treat patients, there was a chart audit that was done to show that despite that, sliding scale insulin was actually being used more frequently to manage patients' blood glucose in hospital. So we did have enough evidence, and there was that evidence to practice gap. So despite supporting research and guidelines from both the Canadian and American Diabetes Associations promoting its use, the uptake of BIBIT over the use of sliding scale remained low. And this discrepancy between evidence and practice is a costly and unsafe gap in effective diabetes care. And as many of us may be aware, evidence alone is insufficient for practice change, even if it has been distilled into user-friendly documents like a clinical practice guideline. So what needs to be done? And this is really only the very first part of the formula for success, the effective innovation. We need to explore the rest of the pieces of the formula. So next up is looking at creating that enabling context. So readiness is assessing and understanding context before implementation begins, and making sure that we consider it at multiple levels. So from the individual to the organizational, and also beyond. You might have to consider the provincial and political landscape. There was a systematic review that was done by Atier in 2013, and they identified 5 key components that are important for assessing readiness and understanding context. And that included organizational dynamics, the change process, innovation readiness, institutional readiness, as well as personal readiness. So we already talked about innovation readiness. And so we're going to discuss institutional and personal readiness next, and then we'll talk about the change process and organizational dynamics. So the first level we will talk about is assessing readiness with stakeholders, and this requires engagement. So that's one of those key pieces that you guys highlighted when we talked about what's required. And engagement is a process. It's not an event. It requires effort, time, and resources. And when you are engaging with people, you need to be clear. Why are you engaging with them? What do you plan to do with the information you are collecting? And you want to make sure you report back to your stakeholders. So engagement is not a one-way, nor is it a one-time deal. So readiness will likely be assessed at different parts of the implementation process, but early engagement and readiness assessment is very important. You need to recognize that they take time, and in a lot of cases, conversations may be better than surveys in some of those harder to engage environments. So when considering your stakeholders, first you need to identify them all. Who are they all? Who all has a stake in this issue? Then we need to understand what their specific interest in this issue is. And then you have to engage with them and develop a plan. So for our BIBIT example, as I mentioned, the Alberta Dawn SCN encompasses all of the important stakeholders. So we have clinicians represented, researchers, patients, families, administrators, and decision makers, and they were all involved in establishing the priority. And in addition to that, the patients were engaged further by this survey. And so this gave us an idea of what their interests were, and it was a way to engage them. And so they explicitly requested improvements in diabetes medication administration. However, the improvements need to be made at the hospital level. So it was important to engage those stakeholders as well. So we had early engagement of the multidisciplinary team at the initial pilot site in Calgary while we were planning for implementation. And you'll see that we continue to engage throughout implementation. So there are tools that can help you find where the gaps are to help you ask the right questions. But again, you need to be clear what your intentions are when you're engaging with the stakeholders and when you're asking these questions. Engagement is a long-term process. So the readiness thinking tool asks questions about motivation and capacity, both at the individual level and the organizational level. The organizational readiness to change assessment tool, it's based on that Paris framework, which covers evidence, context, and facilitation. But as I mentioned, you can use other determinant frameworks like CFR, the Consolidated Framework for Implementation Research, because their domains actually map quite nicely to the domains that were identified in that systematic review. So there's a lot of tools. And if you're not really sure which tool to use, again, there's another website that you can go to that will help guide you through. They'll ask you certain questions about your setting and where you're implementing. And then it gives you some options for tools that you can use. And those tools will give you some ideas of what kinds of questions that you can ask. And this particular website was based on a systematic review that looked at valid and reliable tools for readiness assessment. So there's a lot of evidence that's gone into these tools. So assessing readiness is a combination of engagement, and through engagement, understanding context at both the individual stakeholder level and the organizational system level. So to be ready for change, we must be both willing and able to change. So for our BIBIT example, as mentioned earlier, engagement was pan-provincial through the SCN, and their different engagement strategies had to be used depending on where they were at in implementation planning. So we had to use different strategies depending on whether or not we were working with those early adopter sites versus what we call the late adopter sites, because we're working with different levels of motivation and engagement. And so they used that decision support tool and came up with a hybrid readiness assessment tool. And they created a draft list of questions. And then they gave those questions to people to make sure that they were relevant before they went out and interviewed and surveyed and talked to the sites. And so the key domains that they identified were related to individual and team dynamics, senior leadership and champions, resources, patients and patient needs, the proposed change itself, which was that intervention, as well as communication. So this gave them a way to focus their conversations on what was felt to be most important. So once we've assessed readiness, we need to start considering what this innovation is going to look like in practice. And implementation is about managing change and overcoming barriers. So while you're engaging and understanding context, you hopefully start to understand what and whose behaviors need to change. As mentioned before, it's not really a step-by-step process, but an ongoing iterative process. So understanding context includes understanding who needs to do what differently. And when you're engaging with those sites, you can have those conversations, because that's going to need to be the focus of your implementation. And this will also help you determine what implementation strategies you need to support your implementation. So again, it's about having those conversations with the people, identifying who needs to behave, whose behaviors need to change, and then identifying what we can do to support them. So in terms of our BIBIT example, there was quite a number of behaviors that could potentially need to be changed, but the primary one was focused on the fact that physicians were not ordering BIBIT. So there was that inconsistent uptake and use of order sets despite the evidence. And so that's kind of the first step. And so this was the first big step, that in order for patients to receive this protocol, the physicians needed to order it. So we did recognize that this was in fact a very complex practice gap and in a complex system, and it required more than an educational intervention to create and sustain meaningful change. So if we expect people to change, we need to understand what might be preventing them from doing things differently, or what could be happening or helping. So it's not just a willful, ignoring the evidence. There's other things that could be at play. And so we need to select, identify those behaviors that need to change. And because you can't address everything, you want to prioritize based on some of your initial assessments and conversations, what matters most. And this will help you identify factors that support or hinder that behavior change. So it's really important to understand the barriers and enablers from that frontline perspective, if that's where the change is happening. And there's several ways to get information about barriers and facilitators. And you can start with going to the literature. A lot might have already been published that can help inform where you can start. If you're in the clinic, you can do observations. You can also look at administrative, excuse me, and document review. But talking to your stakeholders is probably one of the best ways, though perhaps not always the easiest. And this brings in principles of integrated knowledge translation, where we always want to be engaging with our stakeholders. So you want to leverage strengths and select targeted evidence-based strategies to overcome these barriers. And this is where theories and determinant frameworks help. So using a determinant framework gives us a structured way to assess what might be getting in the way, to ask the right questions, to understand those root causes. So in terms of our BIBIT example, there was a number of different barriers. Some physicians believed they were already ordering BIBIT. Some were not aware of the evidence in support of BIBIT, although not that many. Some felt it was not appropriate for their specific patients. Others felt the dose was too difficult to calculate. It was too time consuming. But we also had a number of enablers. So we had those key clinical experts that could act as champions. And we also had multidisciplinary team endorsement of the guidelines. So I think there was that agreement that this is the best way to treat patients. So now we just needed to understand what was really getting in the way. And these were some of those specific issues. So we need to look at the strategies. And implementation strategies are methods or techniques that are used to enhance the adoption, implementation, or sustainability of a clinical program or practice. This is the how-to component of changing healthcare practice, policy, or behaviors. It can be a single component, but it's more often than not multifaceted. And this helps prevent us from using that ISLAGYAT approach. It's a strategic approach, and it's focused on the issues, focused on those barriers. So I've got another poll for you to use the annotate feature. So in response to this question, I have been involved in an implementation where the primary or the only strategy was informing people of the change. So either an education or an awareness campaign of the change. It does appear that a lot of people have found themselves in this situation. I'm surprised there's not even any no's. Oh, there's a no. That's good. It's good to see some that's not the only strategy. Okay, I'm going to clear these off. So we want to make sure that we match strategies to effectively target those barriers and enablers. And it's critical to select or specify a theory of change for each level of change you're trying to impact. And there are theoretical frameworks that can help determine which barriers and enablers need to be addressed and which interventions to choose to overcome those barriers and enhance your facilitators. So for our BIBIT example, we developed an evidence-based strategy using the behavior change wheel. So the behavior change wheel is a tool that sets out a systematic method for understanding behavior and linking this understanding to techniques known to change behavior. So it encourages people to consider the full range of options and choose those that are most promising through systematic evaluation of the theory and the evidence behind this. So it has at its core a model of behavior known as COM-B, which is represented in the middle by the green circle, and I'll talk about that in a minute. And it links to a determinant framework shown here in yellow, which I'll also expand on in a minute. So this wheel then identifies different intervention functions in red, which help us determine which strategies to use. And on the outside are policy categories, which can also influence your implementation, but I won't be getting into those in this presentation. So as mentioned, at the heart of the wheel is a model of behavior called COM-B, which stands for capability, opportunity, and motivation, all three of which are required for behavior to change. So there must be capability to do it. The person or people concerned must have the knowledge and the skills to perform the behavior, but that's not it. There must also be opportunity for the behavior to occur in terms of a conducive physical environment as well as social environment. And there must be sufficient strong motivation to do the behavior. So you need to make sure that you're exploring all of these areas and addressing the barriers in all of them. So we need to be willing and able to change. And we don't want to make assumptions about what people need to do this change. So COM-B links to the theoretical domains framework. And this is a determinant framework which looks at those specific factors that affect or influence behavior change in a little bit more detail. So it subdivides the COM components in a particular way to get at those specific aspects of capability, opportunity, and motivation. And this facilitates the development of targeted strategies. And this type of assessment helps us consider what is affecting the behavior we want to see so that we can target our strategies appropriately and not just assume more education is needed. If things don't happen, they just say, we've got to do more education, more awareness, but that's not enough. So with our BIBIT example, we did this little mapping exercise. So for those clinicians that are not aware of the evidence, or if they're not aware of the protocol, this was a capability or knowledge barrier. And so we could use education for that particular barrier, but that wasn't the only one that we saw. For those where they thought the dose was difficult to calculate or too time consuming, this is also related to capability, but it sort of kind of gets more at that, the cognitive skills and also memory, attention, and decision processes, which relate to the ability to retain information, such as the formula to calculate the dose. So we could do some specific training here. But for those people that believed they were already doing it, or it was not appropriate for their patients, well, you could see that they're not motivated to change their behavior. They have no intention to change because they feel that what they're doing is working. So you have to use a completely different set of strategies. And then the last one was related to the weight not being entered in time for the physicians to actually calculate the dose. So the dose requires the weight to be entered, but the way that the clinic was set up, the nurses or the people weren't able to enter the weight in time. So that kind of was a process thing. It was an opportunity and related to environmental context and resources. So that required some restructuring. So you can educate them all you want. If they don't actually have the processes in place, again, it's not going to happen. So as I keep saying, in order to have an evidence-based implementation, we need to look to the evidence to see what strategies work. So a lot of research has been done on a number of different strategies, and this is evolving all the time. Not all strategies are effective, and some may need to be combined with others to become more effective. So we don't want to just abandon education, even though if you look at printed educational material at the top there, they don't have a very large effect. Whereas at the very bottom, if you look at reminders have a much larger effect. So you might say, well, let's go with reminders, it's more effective. But if memory is not an issue, reminders are not going to help you. So we need to fully understand the context and the root cause of the barriers before we select strategies. So for our BIBIT example, for those capability barriers, such as the lack of knowledge of the protocol, they mapped to education and training, and therefore we could select specific strategies to address knowledge and skill gaps that are very specific to those particular issues. So we developed order sets. We had multidisciplinary peer-to-peer continuing education. And then we also created a BIBIT dose calculator that could be embedded in the chart. In terms of opportunity barriers, such as the lack of communication during patient transitions or lack of notification of change in the patient's blood glucose status, et cetera, we could change and improve processes and policies to provide the opportunity to use the right protocol. And we could embed those reminders. But we also had to have a good communication plan that very specifically targeted those issues. And for motivation barriers, such as their perceived workload increase or the perception that it was not appropriate for their patients, we could use provider-specific data audits and different communication plans to help address. So we had to develop a plan to manage change and overcome barriers, and it was targeted and deliberate. So the next step is to make sure it actually worked. So again, we're still in a lot of this is a lot of in the planning phase. So we need to evaluate our efforts. And the primary purpose of evaluation is to provide timely and constructive information for decision-making about particular programs. And you don't necessarily want to leave this to the end either. You want to think about what it is you need to evaluate early so that you can build that into your process. Excuse me. There are various types of evaluations, but there's two main philosophical approaches, formative and summative. So formative is an ongoing process that allows for feedback to be implemented during the program cycle, and summative occurs at the end of a program cycle, and it provides an overall description of the effectiveness of that program. And there are common types of evaluation. Process evaluations are formative in nature, and they help us understand if the implementation worked. So looking at the process of delivering the program, what strategies, when, how, and for whom. Outcome evaluation helps us understand if our efforts resulted in the patient outcomes we expected, and they're summative in nature. We usually have to wait until the program has been fully rolled out. So if we look at process evaluation, as mentioned, they're formative, and so they're useful for monitoring and modifying. So this type of evaluation focuses on improving and enhancing rather than rendering a definitive judgment. So it allows you to track program information related to implementation, and it helps provide those early warning signals and helps you adjust. So outcome evaluation is summative in nature, and so they help you judge the overall effectiveness of a program and are particularly important in making decisions about continuing or terminating the program. So this is more on the deciding and monitoring side. They help you determine the significance, the value, and value. And they contribute to decision-making about whether the program is effective enough to be continued and replicated or scaled and spread. So in our BIBIT example, the process evaluation helped us identify which strategies or tools were effective at changing behaviors, which ones enabled physicians to order BIBIT. You know, we implemented a number of them and they were targeted, but we had to make sure that once implementation rolled out that they were still actually working. And then summative can look at whether or not behaviors changed. So you can look at whether or not physicians are now ordering BIBIT, and if so, are patient outcomes actually improving? Like, are we still actually having the outcome that we wanted to after we've put in all this effort? And then we have to also, at the same time, again, doesn't really come at the end, but we want to consider sustainability because it's one of the most important aspects of implementing change. At the end of the day, if we do not sustain what it is we are implementing, then why are we doing it in the first place? So sustainability is that moment when process and outcome have changed, thinking and attitudes are altered, and the system that surrounds them is transformed. And those new ways of working and those new outcomes or those improved outcomes, it becomes the norm. And so it's not something that is new anymore. But you have to start with defining what sustainability means to you or your program. And different people can think about different aspects of sustainability. So you want to make sure you have a common understanding of what your goal or aim is. Are you looking to sustain that evidence-based practice? Or do you need to sustain the strategies themselves, like the education? And if so, how are you going to continue to educate over time? Or are you just looking to sustain the outcomes you hope to achieve? And you might have to consider any adaptations. So what does it mean to you? And then what are the activities from the current implementation plan that you might need to sustain? And you have to consider who might need to be involved in that sustainability. So it's important to understand what sustainability means for everyone. The next step is to diagnose. And so the factors that affect sustainability are often similar to the factors that affect whether something gets implemented in the first place. So you can use similar frameworks that you did when you were doing your readiness assessments and your barrier assessments, because the factors are very, very common. There might be some things that are different, but for the most part, a lot of it is going to be similar. And again, there are tools that can be used to help you assess sustainability. The Nhs Sustainability Model looks at staff, organization, and process factors. And on the other side, the PSAT includes an external perspective, while the CSAT looks at more individual and organizational level factors. So one is more program level, the Program Sustainability Assessment Tool, and then there's the Clinical Sustainability Assessment Tool. So again, it's important to define what it is you need to sustain, and then these tools can help you ask those questions and understand what you might need to focus on. So for our BIBIT project, we had some examples of some key process points when approaching sustainability. And so ongoing assessment of barriers, we're able to identify new barriers. So if you only assess the barriers before you start, you may miss important factors that will affect sustainability, because we often have to start with perceived barriers. So when you're having those conversations and talking to your stakeholders, it's really about the perceived barriers. And so then you pick those strategies based on those. But once you implement, you need to have that ongoing monitoring, because sometimes what actually happens in practice may not be the same as what people originally thought or predicted might happen. So you need to be iterative and continually monitoring and addressing those new barriers as they come up, and then identifying additional new strategies. So in the case of BIBIT, these strategies included additional provider-specific audit and feedback report cards, restricting the availability of the electronic sliding scale insulin order sets, and additional resources to address the barriers associated with transitions back to the community. And there were also policy changes that needed to be implemented to help support improved glycemic management overall. And so our goal was to sustain improvements in glycemic management, as well as specifically maintaining the use of BIBIT. And so the Dawn SCN provided hospitals with these visual updates of interim data to show progress and encourage that sustained utilization. So it's that ongoing monitoring and evaluation. And it's not a linear one-time process, but this sort of audit and feedback, that reinforcement, just helps the sites see that they're doing well. And so at the time this was unpublished data, I'm not sure if this has since been published, but this was just a snapshot from the Chinook Regional Hospital, that after, I think it was 3 or 4 years, we were able to demonstrate a sustained increase in BIBIT ordering. And we were also able to demonstrate that this resulted in reduced hyperglycemia in hospital, which was also sustained. So this was just really nice to be able to see that all of the efforts that we put into this were able to be sustained long-term. So our primary lessons learned were that engagement at all stages and levels was very important, ongoing engagement. Using theory to design strategies improved success, and that implementation is not a linear one-time process. So I just wanted to acknowledge the team that I worked with specifically. Dr. Carmen Helmley, she was the physician champion of the Dawn SCN. Dr. Julie McKean is the medical lead of the Dawn SCN. Lita Philp was the clinical practice lead, and Dr. Naomi Popesky is the assistant scientific director. And of course, I'd like to thank Chinook Regional Hospital for allowing me to share their data. So that was a lot of information in a short period of time, but we have lots of time for comments and questions. So I will maybe end the slideshow here so that I can see more of the people, and then we can open it up for questions.
Thank you very much, Gabrielle. Yes, we have a good 15 minutes, if not a little bit more, for questions. So please either raise your hand or type something in the chat box, because Gabrielle's all ears, and as you can see, she is a wealth of information. So please take advantage of that.
Oh, I have to start because it's Diana. Hi, can you hear me?
Hi, yes.
Yeah, so I'm one of these people we call patient partners. So this all started with, a patient issue, but how can patient partners be involved in this whole implementation side of it? Like, it didn't show up a lot in any of your models, theories.
That's true, and I think it depends a lot on the nature of the project. And this started out as a priority for patients, but as I mentioned, the improvements needed to be made at the hospital level, and the primary behaviors that needed to change were related to the physicians. The team did develop some patient tools, some patient, what am I trying to say? The patient pamphlet to help them understand how these changes would impact them, or how their care was being managed with basal bolus insulin therapy, and how that was similar to what they would probably normally be doing at home anyway. So it was a way to help them understand, why they would have been getting that particular protocol. But for the most part, that was what they had wanted, was to have something more similar to what they're used to doing, and not having these whole scale changes. For some patients, it was a change. And so that's where, as I was mentioning there, and I didn't talk as much about it, but when they actually did the implementation and started doing this, they were recognizing that those transitions back to community were becoming an important, not necessarily a barrier, but an important issue that they needed to focus some of their strategies on. And so I don't recall at that point if they did specific engagement strategies with the patients, but because the Dawn SCN has patient and family representation, I think that they were able to help inform the tools that were being developed. And so I think that we probably could have done more engagement, and I wasn't as involved, after I helped guide the initial implementation. I might have to go back and talk to the team about any additional patient engagement they did, because I'm not aware of everything they did, but they did try to address, the patient's needs in those transitions as well, as far as I know.
Yeah, I just wondered, over 25 years ago, Health Canada gave millions and millions of dollars to oncologists across Canada to develop clinical practice guidelines around breast cancer. And they produced the professional guidelines. They produced, I think it was 6 booklets addressing different areas for patients. And they also developed booklets for Indigenous people. And my oncologist was part of that team that developed. And he just, his whole point was that these had to get into the hands of patients. You took these booklets to your oncologist and said, are you doing this or not doing this? And it's that kind of activity that I always think is useful, but maybe practitioners don't think is useful, of patients advocating for this change.
I think it's great that patients are, advocating for the changes and are able to bring that forward. And I think that's, in hospital, I think the physicians, especially for this case, are probably more focused on what brought those patients to hospital in the first place. And in addition, they also have to manage their diabetes while in hospital because the patients aren't able to do that. So the hospital kind of takes over. And so I think in that case, it was more about bringing awareness to the physicians about the importance of managing their diabetes as closely to what they would do in home. And there probably is ways that the families and the patients could advocate for themselves. And hopefully some of the patient materials that were created are able to do that.
Thank you. This presentation was wonderful. Lots of stuff. Wonderful. Thanks.
Thank you, Diana, and thank you, Gabriel. We do have a question from Karen McDermott, and I'm just wondering, Karen, if you'd just like to turn your mic on and ask that question.
Yep, sure I can. I was just actually looking at my exact wording of my question. It's just, can this implementation process science, could you apply it to team building and changing a philosophy of team approach to care?
I think that you could, because a lot of the theories and frameworks that are involved, they do look at how we can address change. And so even if it's not implementing a specific intervention but if you're looking at changing someone's behaviors, you can use these kinds of models and frameworks to help you understand what might be preventing them from changing and what kinds of strategies you could use to help support them in those changes, in addition to any education and the building of awareness is always that first step. You can't really have change without people being aware of what needs to change. So I think a lot of building awareness can come before you get into full-scale change, but I think some of these implementation methods could apply for teams, especially if you're looking at changing the way the teams function.
Thank you.
We also have a question. Fiona, I know you've written it in the box, but would you like to ask your question to Gabriel?
Sure, that's great. Thank you so much, Gabrielle. This was such a fantastic presentation. I really enjoyed it. I was wondering if you could perhaps elaborate a little bit more about concrete practical steps to engaging leadership and policymakers to be able to integrate evaluation findings into practice. So, for example, you've done an evaluation, you've found some things, you have some recommendations for change, you've identified things that need to be changed. How do you then integrate that into practice and not let it just get put on a report that sort of doesn't get read?
Yeah, that's a great question. I think you really need to, again, understand, who is it that needs to be, at the table having these conversations. And if you're presenting these recommendations to people, I think it's also useful for them to understand what is it that they can do to support the change and what is it that you want them to be able to do and to be able to offer up that opportunity to support them again in that change. So if these policymakers need to change the way they're doing things, we need to help them understand what that is and how they can facilitate that change or what they need to do on their end in order for this to happen. But for a lot of people, you really need to focus on what's in it for me, or why should I care? And so whenever we're creating these knowledge translation materials, we have to, like when we go into the clinic, it's really important for us to understand their perspectives and understand what this means to them. And then, help them understand why this is important for their work and for their patients. And I think we need to do the same with those higher level leadership and executives and policymakers to help them understand why this matters, not only to patient outcomes, but to their bottom line and whatever it is that they have influence over, and helping them see where their piece fits into the larger puzzle of creating that change. Because not any one person is able to do everything, but everybody has input and has, you know, the ability to contribute. But we just have to help them see what they are able to do and help them, you know, identify strategies that they can use to contribute. I hope that helps answer.
Great. Yeah, thanks very much.
Thanks, Gabriel. Amir, I see you have written a really great question about scaling. And if you'd like to ask that, that would be great.
Sure. Thank you, Kristen. I hope you can hear me.
If you can speak a little louder, that would be terrific.
Okay, sure. So thank you very much, Dr. Zimmermann, for your very wonderful presentation. As Kristen mentioned, I have a question about the scaling of an implementation project or initiative. One of the challenges I have encountered in my experience, not very much, but in my experience, is how to decide about or determine the scale of a project. So for example, should we start with, let's say, one hospital or one health region, or engaging multiple health regions, or do that specific implementation project provincially? So I wonder if you have comments about the subject of scaling an implementation project. Thank you.
Thank you. Yeah, scaling, a lot of what you need to consider when you're scaling is, of course, your resources. And with our BIBIT project, we started in a pilot hospital in Calgary, and then we started to trial it in some rural hospitals. And in doing so, we continually gathered information about potential barriers. And because of the mapping exercise we did, we were able to identify very specific strategies, and then the team was able to develop resources. And so at the end of that, we were able to create a toolkit that was available to other sites that were looking to implement BIBIT. And so this became more of a spread effort. So we created the resources and tools so that other sites could take it up on their own, versus if you're looking to do more active scaling up, you need to have those resources. And then it's just useful to use those resources and tools and have them available, but also to continue to do that ongoing and monitoring to see if there are new barriers that might show up, especially if you're going from, say, a hospital level or a small unit level to a hospital level to a provincial level. There might be other considerations. So you might need to think about, you know, at those different levels, what are those additional potential barriers or facilitators that could affect the implementation. But the information that you learn from any given site or hospital or your, you know, initial implementation can help develop those resources and tools that then make it that much easier to spread and scale. I hope that helped.
No, definitely it helped. Thank you very much.
I think we have time for one more question, and I'll ask Maeve to ask her question, but we will be taking all the questions, and we're hoping, Gabriel, that you'd be able to answer them maybe by email or something, because there is certainly a few more people who have questions that they'd love answers to. So we'll capture that in the chat room there, and we'll get answers to you. But in the meantime, we'll ask Maeve to ask her questions, and then we will, and then we'll have to close our session.
Thanks, Christine, and thank you so much for the presentation, Dr. Zimmermann. It was fantastic. This completely relates to all the work that I do. So I work predominantly in evaluating mental health and addiction programs where kind of outcomes are not necessarily immediate, and there can be a lot of confounding factors when we are looking at outcomes. So I'm just wondering, how can implementation science help me in my field, and especially when, you know, the outcomes are a little more complex and more time and require more time to really come to fruition. So I'm just wondering if you can speak to kind of more complex mental health and addiction issues, and how implementation science can help in those areas.
Yeah, that's a great question. And I think it depends on what exactly it is you might be implementing. So you might be, if it's a program and you're evaluating, I think it's useful to understand. So the one way that I like to look at it is to develop a logic model, excuse me, because I know you're really focused on those long-term outcomes, but there are probably a number of intermediate or short-term outcomes related to some of the activities in the program that you can evaluate and demonstrate some improvement on. And those logic models kind of give you that, well, if we do this, then this will happen. And if we do that, or if that happens, then this will happen. And hopefully that logic kind of flows through to give you those long-term outcomes. But as you say, you won't know until maybe several years down the road whether or not that's happening. So you might have to focus your evaluations on some of those processes and activities that are leading to some of those longer term, or like that lead to some of the more intermediate outcomes. Like even if it is about raising awareness, as I said, raising awareness is sometimes that intermediate outcome that needs to happen before more changes evident. So you might need to, you could use implementation science to help identify, you know, what exactly you do need to raise awareness about, or, you know, what is the knowledge base that needs to be built. So I think there are different steps. And as I mentioned in the beginning, there was that continuum of activities, and we don't necessarily want to rely on diffusion, but dissemination is, you know, having more targeted strategies. And then implementation is sort of trying to facilitate more of that, but you might need to focus more on those dissemination efforts. And there, I think there are some theories and models and frameworks that could help inform how you set up your evaluations or how you use that evaluation information. So, I mean, it is very complicated and it's hard to say exactly, but I think there are those opportunities.
Thank you so much.
Thank you very much, Gabrielle. We appreciate so much your presentation and all the information. Just a reminder, Gabrielle's presentation has been recorded, and we'll be sharing it on our SCPOR website as well. We know that so many people have asked for the slides because there was a wealth of information, a lot of references, and so we'll have a link for those. We'll send a link to those for everyone as well. So again, thank you so much for attending. We thank you so much, Gabrielle, for this presentation. It was a great information and so applicable. So on that note, I'd like to thank everybody and ask everybody to fill in the evaluation when it does come around. And once again, a good day to everyone. Thank you.